All across Canada, patients and doctors are asking for change.
Doctors would know my name, not just my symptoms.
They would understand our culture.
We would be empowered to treat patients and teach students.
To leverage AI so we can improve our quality of care.
Through a bold new approach to medical education, the Toronto Metropolitan University School of Medicine is creating that change.
Attention hospital HR in Canada, are you in search of the perfect insurance solution for your part-time and casual employees? Look no further. Meet Healthcare Providers Group Insurance Plan, your go-to option for ensuring the well-being of your team.
With healthcare providers, also known as HCP, you're not just providing insurance, you're providing peace of mind. HCP's comprehensive coverage includes medical, dental, and vision benefits designed to keep your part-time employees happy and healthy. There's even a package that includes life, long-term disability, and accidental death, disease, and dismemberment coverage for those who already have other group health and dental coverage.
It's time to bridge the gap between full-time and part-time staff benefits. With Healthcare Providers Group Insurance Plan, you can level the playing field and show your commitment to all of your team members.
Join the community of over 145 hospital sites who have made the smart choice. Visit healthcareproviders.ca today to discover how HCP can help you support your team in a meaningful way.
Is this thing on?
I think they can hear us a bit better now. Do you think they are ready to change the status quo?
It's one thing to get them listening, but now let's get them to act.
You are now about to witness the strength of nursing knowledge.
Hi, and welcome to the Gritty Nurse Podcast, an unfiltered and unapologetic podcast which discusses health and healthcare. My name is Amie.
My name is Sarah.
And we are your hosts.
Don't forget to hit the subscribe button wherever you listen to podcasts. Google, Spotify, iTunes, or our YouTube page. Please rate and review us.
Make sure you get our book, The Wisdom of Nurses. There's no better gift than giving the wisdom of nurses to nurses during Nursing Week. Hi, and welcome to the Gritty Nurse Podcast, an unfiltered discussion related to health and healthcare. My name is Amie.
And my name is Sarah.
And we are your hosts. So today we have such an exciting guest on our podcast. We've actually had her on before, but this is going to be a little bit of a different angle and a different role for her as well. And let me just read a little bit about not the person that we're talking about, but the perspective where we're coming from. Because, one of the conversations right now really surrounds about having more physicians. Well, if we want to have more physicians, we need to have more med schools. So I'm going to read a little bit of a line off of TMU's School of Medicine's website. So they're creating healthy change with our bold new School of Medicine. So it says, we believe change starts with education. That's why we're tackling healthcare gaps facing our communities by introducing a bold new medical school. At our School of Medicine, we will shape future-ready doctors who are dedicated to delivering primary care to those who need it most. Doctors from our communities will work with our communities to improve health and well-being. And doctors who, through our pillars, our guiding principles, will advance our shared vision to build a healthier, more equitable world. So without further ado, I can't wait to hear from Dr. Teresa Chan.
Yeah, and just before you start, Dr. Chan, I wanted to read a little bio about yourself. So Dr. Chan is a Canadian emergency physician and medical educator. On July 15th, 2023, she became the founding dean of the Toronto Metropolitan University, also known as TMU School of Medicine. She is currently a practicing emergency physician and clinician educator at Hamilton Health Sciences in Ontario, Canada. She has formerly served as the Assistant Dean of Faculty Development and Associate Dean of Continuing Professional Development within the Faculty of Health Sciences at McMaster University. Dr. Chan is also the founder and editor-in-chief of the medical education website, canadiem.org, which provides resources for medical learners and educators in Canada and around the world. She is a well-known figure in the medical education community and has received numerous awards for her contribution to the field. Welcome to the Grading Nurse podcast, Dr. Chan. We're so glad to have you.
Thank you so much for the introduction. Just one thing that I wanted to correct for the record is that I've transitioned my practice from Hamilton Health Sciences, where I still hang out sometimes there and help out when I can. But I'm at the William Osler Health Sciences Network now. So yeah, it's a privilege of mine to have started at our primary affiliate site, which is with William Osler Health System. So that's really exciting.
Yeah, that's amazing.
And from what I've heard, you are so busy and you wear so many different hats. And I just wondered what led you to take on this amazing achievement of the founder of TMU Medicine?
I mean, I think there's lots of people that have been helping with founding it. I'm just the founding dean, which means I get to bring the team together and really carve out a new way of doing things. But I'm indebted to the people who've come before me, the professors around TMU who volunteered to be on committees, to even just like scope out, how like people who become the presidents of the US, they often have a committee that explores whether or not they should do something like become president. Well, guess what? There was like an exploratory committee that really came together to like carve out what we thought a medical school should look like at TMU. And then after that, they hired Andrew Padmos, who was formerly the CEO of the Royal College, to lead something called the Senior Medical Advisory Committee, SMAC. And they worked on this project for about a year before I was hired. Andrew stepping back really in a very like cordial, gentlemanly way. As soon as I started, he was like, okay, now you're it. But do you want me to come to your meetings and help transition? I'm like, of course. And so although I'm the founding dean, I didn't start the medical school from scratch. So many people, including our president, Mohammed Leshmi, and our provost, Dr. Roberta Provenzano, Inachito Provenzano, sorry. She has a long hyphenated name and it's wonderful. I've learned how to say it. I just sometimes forget to say all the parts. And they've been so supportive and wonderful alongside all the people, all the other deans, all the other faculty members at TMU who have been working on this project for longer than I even knew it existed. And so with that fact is that I joined this organization because I believed in what they were trying to pitch the world.
Right.
And the project, which was well defined, which was to build a school with equity poured into its foundation, into the bricks, was something that really appealed to me. And the chance to do something in the GTA, because there's only been one medical school in the GTA, for almost 200 years, like 170 something years, right?
Wow.
Yeah.
And wouldn't it be nice if there was another way of doing things, not necessarily better, not just different, right? And I think that what you can do when you're in an established medical school is that you have all this privilege becoming the dean of an established organization, but you also have so many people to take care of and many voices to acknowledge and listen to. And though we have to do the same thing and respect the people that have come before us and acknowledge what they've done, I do think that there's still a lot of creativity and inventiveness we can roll into what we're doing. And that's the great privilege that I have, is in areas that were not yet defined, which is quite a few of them, to be able to lead a team to define what that looks like, and sometimes get to define it myself.
Yeah, that sounds amazing. And it sounds like it's a lot of work. I am sure that it's been a massive undertaking. And I think, again, you're not giving yourself credit because, again, there's still a lot of work that you've been doing. And I think your name carries some weight as well in terms of all the work that you've been doing. But you did mention something that I want to touch on, which is some of the innovation, the fact that equity is something that's a theme within the school. So TMU boasts a new model for training its future physicians. Could you expand a little bit on what this might look like?
Yeah, so I mean, I think the new model for how we're going to train physicians really is in a very clinician first kind of environment where we're going to lead with clinician educators in the clinical spaces, bring the trainees in early, and really listen to the needs that the clinicians are telling us that the world needs from the next generation, which is to fold in things like equity and cultural, not just competency, but culturally sensitive care. That's
Right.
excellent. That we need to fold in technology because, you know, I mean, the two of you are nurses and you still practice. So, we're still using fax machines and pagers.
Yes.
Yeah.
Pagers. Yep.
Yeah.
Wow.
And though we can evolve beyond it, it's a lot of change management and also sometimes just pragmatism because, yeah, pagers have better reach. Some places in the hospital that have dead zones get it. But at the same time, I think there's innovations to be had. And so, a lot of clinicians and a lot of people out there were like, we need to make sure we fold in technology. We also need to make sure that we're paying attention to some of the other needs, right? So not only do we need to function that multilingual, multicultural way, we also need to think about what it means to make sure we provide great care to those who are aging, the older patients and what they need, but also older clinicians and what they need. So we need to care for our elders in a way that maybe we haven't had that as a strategic pillar within a medical school before.
Right. No, I think that's amazing.
Yeah.
And then I think the other thing that we folded into our mix was to think through how do we build for the future of team-based care so that we are doing this interprofessional care so that we see and understand all the other parts of healthcare so that we can build better systems and function as a collaboration, as a team. And I think that requires us to bring in things like health system science and that interprofessional lens that respects that, nurses, PTs, OTs, social workers, even people who are like porters and logistics people, the biomedical engineer, these interprofessional providers who are all throughout the healthcare system have their lens and they can bring in their expertise, right? So, for instance, everyone's got a family doctor and they've got I wish, right? But those of us who do have one,
right.
There's the front person at the reception who has this wisdom to getting things done in a way that maybe we can't see the opportunities. And so when we think about innovation, how do we involve everyone at the table to think about how we do scholarship, research, QI that really folds in all of the expertise? And so I think that's something that we really need to bring together.
Yeah, I think that'll be really important. I think that's probably one of the things just traditional healthcare has missed overall. Like we are really good at building silos actually, and I think this is something that sounds like a really great innovation to really start. It's kind of practical and common sense. It's like, okay, we need to fold into all these characters who are doing this work to make sure that we have a well-oiled system. And, I'm going to be looking forward to seeing the practicality of it because it should be something that's super easy. But again, we know there's always challenging personalities and it'll be really innovative to see what TMU does to kind of bridge these gaps. And again, Brampton is like my hometown. I can't believe that there's only one hospital in Brampton. That's a whole other conversation, but I think it'll be really important. There'll be two.
Yeah.
But I think again, two like PMC, like PM Memorial Center.
They're expanding it. Yeah. It'll take a couple of years, but it'll get there.
Okay.
Yeah.
But it's just like, in Toronto, there's so much more. And I think again, we need to see this in communities like Brampton as well. And I think one of the things people would say is Brampton's a community hospital. I don't think so. In terms of the experiences I had there, I can't imagine. And I'm glad that it's going to be a hub and a learning center.
Yeah, and a lot of things that you mentioned, it seems like for a long time, people have viewed medical schools as very top down and very antiquated, and that may not be true. But one of the things you mentioned is that it seems to be student and clinician led, and there's a lot of initiatives around inclusion and bringing us up to speed and more relevant, right, using technology. So would you be able to speak to some of the things that you feel set TMU Medicine apart from other medical schools across Canada? And like you said, it's not better, just different.
Yeah, and I think that like most medical schools in the accreditation standards, it says we have to be socially accountable, that we have to know our communities. But I think that when you don't have to run a medical school while you're planning a medical school or planning a great change, you have the chance to just listen. And I think that's what TMU really did, was they went into a community, not while there were like 7,000 learners running around and doing all their things, but rather before things started, like listened to the community, took notes, used those notes to fold in, develop our pillars. And that holistic approach, that community first approach, I think is the reason why we have such a strong allegiance to these trends that are coming about. But it's also something we want to make sure we fold into every aspect of the school. So rather than just saying, okay, we listen to the community, we're done listening to them, move on. We are also thinking about, okay, so what does that mean to have community-based participation within the school on some of our committees? Well, what about, rather than some, why don't we think about all, right? And so how does it look like for us to have people who can represent the voices of the community to help us evolve the medical school as we go? And how do we make sure we fold in checks and balances so that rather than being siloed off, that we actually listen and try to respond to the numbers and the data that we're getting? So an example would be, most of the time postgraduate medical education is residency, that's residency and fellowship training.
Right.
It's kind of like most programs, if you go from year to year, you'll see, they're like, oh, we've had 4 emergency medicine spots, and then now we're going to 5. And I'm like, that's great. But how did that decision get made? And I think what we're trying to do is we're trying to say, okay, so rather than it being something that the post-grad office wheel and deal and talks to the emergency medicine program and say, can you take one more learner? Why don't we look and see, what do we need in this region? And do we actually need an emerged docs? The answer is yes, definitely, because we don't have enough of them from Canada. So that's a safe one to bet that we could expand that program. But knowing that there's some rate limiting parts, the program director has to be involved. But we should start with a community-based question of, will we be able to employ this fine doctor when they graduate in our region? Because that's what the region needs. And if the answer is yes, then we go through and say, okay, can the program do this? If the program can't do it, what do we need to get the program there so they can do it? And I think that's going to be really cool, is working with feedback from our community sites, from our region, and say, okay, you know what, we're starting a rehabilitation center at, let's say, Peel Memorial, right? Like they're planning to have some inpatient rehabilitation. Well, that means that forecasting backwards, probably need to start a physical medicine rehabilitation program soon in the next couple of years,
right?
So that we can have people who are trained here that will then become the first generation of doctors who will stay and be part of that rehabilitation center, right? Wow. And so that's what we want to try to do. Now, can we always nail it? No. It'll be like that show, that cake show, where it says nail it. Like,
I love that.
We're not always gonna nail it, right? We're gonna probably sometimes need our friends and colleagues and community to speak up and say, yeah, okay, you know what? We're pretty good. Like, we don't need this kind of doctor anymore, and we'll start adjusting our numbers as we can, right? And so we will probably not get it perfect, but we can sense make, I think, with better data these days, and maybe be more responsive and agile.
That's actually sounds like, I mean, I can't even speak to the fact that it sounds like it's a really good plan. I think that we have to be reflexive. We've seen that, medicine or healthcare, whenever these situations go stagnant and we're not being innovative, we only see poorer healthcare outcomes. So I think the reflexivity of the fact that you will go back to the communities and say, is this even working for you? And to listen to their responses, I think that's a huge step in terms of being progressive in medicine. And I think we need more progressive thought within medicine. And it kind of dovetails into a little bit more of specific questions that we have to ask you in relation to TMU as well. So talking about progressive and talking about ideas behind having more racialized folks within medical school, so Black learners as well as Indigenous learners, There was a study that was done in 2020 where Black students represented about 1.7% of the medical students, while census data showed that Black people represented 6.4% of Canada's population. So I did see that there is quite a defined Indigenous pathway, but how will TMU address the inequity related to the lack of Black students in attendance within medical schools as well?
Yeah, so I don't know if it's widely broadcast yet, but we will have a Black pathway for Black flourishing. It's a pathway for Black flourishing, and that's really what we are aiming to do, is really support the flourishing of Black people in medicine as a pathway right from the get-go. We also have a Black health lead. Her name is Dr. Teresa Chan. She's been leading the initial phases really of sketching out what it looks like to have an office of Black flourishing. What are the programs? What are the requirements? What are the resources that we'll need in order to make sure that we support both learners and faculty. And our HR team at TMU also supports staff. So that's why we're not necessarily doing it, because they have a bigger and broader strategy for that. But I would say that having come from elsewhere, having trained at Western and been at U of T before that, and McMaster most recently, I would say that when I walk into rooms at TMU, I'm always floored by the amount of diversity. And I don't think I always notice it anymore. But then when I go to other places to visit and I look at the people at the tables and they don't look like the three of us on this podcast, let's just put it that way.
Yeah.
And I notice it. And if anything right now, I'm not kidding, and you'll think it's kind of a cute, I think, but I've had several email chains when we're doing selection and we need to aim for diversity in, a committee. And several people have remarked, I think we have a gender imbalance. And I'm like, oh, so how so? They're like, we have 6 women and 1 man. I'm trying really hard to fill this last spot. Do you have any gentlemen that you think might want to step up and actually be part of our selection committee? And to me, I think that's a testament to the level of diversity and commitment that we have, is that we're trying to make sure equity is for all.
Right.
And that even when, normally you would think a committee full of women, you don't have to necessarily tend to it, but I'm very cognizant that we make sure that our male colleagues are heard and see themselves represented in the leadership structures. And I know it's like, in nursing, I think maybe it's less of a problem, but in medicine, I think the two of you know, even at the highest echelons, it's getting better, but it's still not quite at parity, because half of all medical students roughly that enter medical school are women. Half of them are graduating. And then somewhere along that leaky pipeline, we're not always making it into, the dean's suite, let's say, right? Not the C-suite, but the dean's suite. And I think we're getting better, but we're still not quite there yet. So it's refreshing for me to start thinking about, okay, so now we have to lead by example. Now that I am a woman in charge, I have to make sure it's not just the reign of the women. We have to make sure that we actually make space for our male colleagues, because they have a perspective, and the way that they see things will actually add diversity and strength to our decision-making, to our teams. And I think that that's what we want to role model.
That's amazing. I think it's really important to not just give people a seat at the table, but also take their, their thoughts and opinions seriously, because that's something Amie and I talk about, is having a seat at the table is one thing, but actually being able to influence change is another. So it's great to hear that you're trying to fill the gaps where you can, and, being cognizant of groups that may be not represented. Attention hospital employees and retirees in Canada. Picture this: a benefit plan designed for casual and part-time hospital employees and retirees who aren't covered by their hospital's group health plan. Introducing Healthcare Providers Group Insurance Plan, a friendly partner dedicated to your health and well-being.
With affordable plan premiums and an exceptional support team, Healthcare Providers, also known as HCP, is dedicated to helping you every step of the way. Enrolling is easy, and you'll have access to a wide range of health and basic dental benefits from day one.
Already have health and dental coverage through another group plan? HCP still has your back. For less than $32 a month, The signature package, which includes life, long-term disability, accidental death, disease, and dismemberment, provides valuable income protection and peace of mind for the unexpected.
So take charge of your healthcare and financial security today. Visit healthcareproviders.ca to learn more.
It kind of leads into my next question, where we talk a little bit about culture in medicine. And we tend to usually have nursing students reach out to us about our experience, but on the odd occasion, we have had medical students reach out as well. And this is an issue that is very common in nursing, but how will TMU address bullying, if anything, along those lines within the medical school?
I think it's so pervasive in some environments that you don't even call it anything because you just assume that's the way it is. And that's the worst kind, right?
Right.
That kind of oppression is just the oppression that's accepted as the norm is the worst.
Right.
And so at least in nursing, you've started the conversation. You call it bullying. I would say that in many circles that I've been in, and even my own rotations, when I think back on it, it was probably bullying, but I didn't even have the language for it.
Wow.
So I think that we need to think through, how do we make sure we raise awareness that equity isn't just about who's at the table, but it's about how do we invite voices in and make sure that they feel respected and seen as people in every way, right? So whether they're a learner, whether they're a teacher, whether they're an interprofessional care provider that's on a team, how do we make sure that everyone feels like they're supposed to be there, that they're worthy, and that they have some expertise to give? And I think that's the question, that if we can bake that again into our procedures, into the way that we conduct ourselves, the way that we think about it, and to have everyone say, okay, no, we haven't heard from, Hardeep. Hardeep, you haven't given us any information about how you think about this. Could you share your wisdom, right? How do we teach people the language to not to bully, but rather to anti-bully, which is invite people to the table and make them feel like they've been heard. And I think that that's a transitional culture that takes a long time. Because when you come from that background of having felt like you don't belong and having no voice, when someone calls you out and asks you to do it, it's hard too. So we have to support all of our people in learning this journey together. And Amie, you were going to say something. Please go ahead.
Yeah, I was just going to add the fact that, in nursing particularly, typically, we have lateral violence. We also have horizontal violence. That's what we call from, our administrators or whatnot.
Oh, yeah.
But again, a lot from what we hear from medical students is that aspect of shame, right? So that they feel shamed about not being able to do a procedure right, or that, whoever they're learning under has made them feel shameful. And that is probably one of the biggest things that we hear about in terms of complaints or, fears with even attending, their residency spots. And I think the other piece is yes, calling it out is one, but it's also maybe changing the structure of the hierarchy. If we talk about medicine in general or healthcare, it's still very hierarchical. And again, I've always been a proponent of flattening that line substantially. But in medicine, I can only imagine how much more hierarchical it actually is. And is there any plans at TMU to try to flatten that hierarchy so it's more of a shared experience? Or is there the conversation is just really starting?
I think we can expedite because we don't have something to break down first and then reveal. So I think that that's important for us to think about, right? So I think the big part of what we need to do is have that conversation with our teachers as we're doing faculty development, so that they see their role as having that caregiver, caretaker role to the trainees. Because I don't think they do that to the patients very often. And most people will say, well, we have to be patient-centered. That's been absorbed. How do we bring in the learner-centeredness? And then how do we do it with our non-teachers that are in the environment as well? So how do we reach out to our nursing colleagues? So any of you Osler nurses who are listening, high five, I'll high five you in the hallway. If you're looking at how you can be a great mentor, teacher, be the Carla to the JDs that we're bringing in. That's from Scrubs, like, because we need people who are going to take our trainees under their wing, even unofficially, right? Because that's what Carla did for JD and Turk. I mean, she married Turk, so that's different. But like, with JD and Elliot, Carla was really important to their development, right? And sure, she was their age, but she had a decade of experience, right? Yeah. So I think that that's huge. And if we can do that, that is the best thing that we can do, is to create that that sense of camaraderie, to create those friendships and allyships. And I think just like anything else, you conquer hierarchy by creating relationships. And then I think that sometimes some hierarchy is important, right? Because the hierarchy that we have is there for a functional reason, which is that when we need to make really fast decisions, we need to have that. So in a code, in a resuscitation, right, I can't consult everyone before we decide to give epinephrine.
Right.
That would be not appropriate, and that would be a threat to patient care. So what we need to do is we need to teach people when, in certain circumstances, we actually have to just respect that the hierarchy is there for a functional purpose. But when it doesn't have that functional purpose, like it's not in the middle of a board meeting,
right,
and just like having coffee, and the hierarchy doesn't have to be there, that we can dismantle it in a way that allows people to feel seen and heard and respected. I think that's the key. And I think it's a little more complex than just dismantling a hierarchy. I think it's about why does this hierarchy exist here? And in which situations do we need to say, hey, look, yeah, the chair of the board needs to move on because we have 5 minutes, and everyone might want to talk about this for an hour and a half, but we won't get to these other items, and those items are important too. And so how do we navigate all of that? And I think our learners need to understand that, yeah, sometimes it's important for you to call that female physician as a male med student, Dr. So-and-so. And that hierarchy is not because of bullying. The hierarchy is that you're being an ally to her, because chances are that older set of patients and their family may actually think you're the doctor, and you don't want
she's not.
Yeah, she's not. And that you may be put in an awkward situation because they're going to ask you to validate what she says. And by you saying Dr. Chan is my boss, may actually help clarify something that is confusing for others. And so I think we have to waltz that fine line, but having nuanced conversations about it is a great way to foster that. And we're going to be engaging in that kind of work with our faculty development, to question what we've experienced ourselves, to process that shame that we might have felt for not knowing how to do a procedure. But then for us to all say, yeah, well, if I didn't know how to do that procedure, I wouldn't do it now. Okay, well, let's normalize that for the patients, and that's for their safety, but it's also for the learners. So they know that if they don't know how, the patients are most important. So you need to say you don't know how, and then we'll help you learn it.
Yeah.
And the patient also should be able to be involved in that decision of whether or not they're involved, right? So yesterday, an example, there was a trainee who was on shift, not my trainee, he was working with some other doc, but there was a complicated lip laceration that it was really interesting. And inviting in that person to be a guest teacher, inviting this person in to be able to be a part of the journey. I did so many lip lacerations yesterday. But in this case, this person was really enthusiastic and became someone who actually engaged in that person's teaching.
Yeah. No, I agree. I understand that there will be hierarchy in some instances. I guess I was more related to the aspects of shame and bullying and this type of violence that we do see, and really the belittling that even myself and Sarah felt when we had our own instances with our leaders who didn't, recognize the fact that, maybe we don't have expertise all in this particular area, but we come still with knowledge and understanding, and that at the end of the day, we need to be treated with respect because we're humans, right? I think that humanness factor is so hugely important. Yeah. And I hope that, as as you continue to, traverse the medical school, that people still will remember that at the end of the day, you're dealing with another human being. Mm-hmm. And it actually dovetails a little bit into an advocacy question. And I think this has been a little bit of a popular topic in terms of what advocacy should look like in medicine and within the culture of medicine. So let's talk about advocacy. So Dr. Yiping Gee was suspended from his role as a medical student at the University of Ottawa after posting pro-Palestinian messages on social media. Does TMU have a stance on free speech, or what does advocacy look like for medical students or even teachers and faculty at TMU?
Yeah, I mean, I think that what we need to think about is, what does that term advocacy mean in healthcare? And I think that there's actually been several other papers written around this topic. It's been a very hot button issue in medical education. I would say that, first of all, academic freedom is really important, right? So academic freedom is one thing. The separate part that we have to wrestle with in the professions like nursing and medicine, pharmacy, optometry, any of the health professions, is that we have to create safe spaces for our patients. And so when we're advocating, so long as we're advocating in a way that allows everyone to feel safe coming to you as a clinician, I think that that's got to be the way that we do advocacy in what we do. And so that means being able to see all the angles of how someone might feel unsafe. I think all three of us can probably relate to someone having a certain kind of symbol, maybe tattooed to their arm or their chest, that made us feel uncomfortable, right? As clinicians, we still have to take care of that patient. The patient doesn't have any duty to care for us. And so they may have those things, but we have to then take a deep breath, think through, process later, but save this person's life, regardless of, what tattoos are on their body and what slogans and what's written there, because that's the right thing to do for that patient. Now, if the reverse were the case, where you had beautiful insignias that made a patient feel uncomfortable, I think we'd have to have a conversation about what that means as a clinician and what that means for your patients who you have to take care of. And it's one thing if you're a provider who has choice in who they see, but if you're on call, if you're part of an emergency department, for instance, like I am, sometimes the patients don't get that choice of who to come to and see. And so I think it's important for us to be cognizant that these things can drive wedges between us and our patients.
Yeah, so, sorry, go ahead, Teresa.
All of that to say is that I think advocacy is one of those emerging concepts that as we evolve our professional identity, it also changes the way that we can advocate. Because what you might put in a tweet could someday turn into something that becomes a barrier for you and your patient. And that's what we need to be having discussions about for our faculty, for our, who are clinicians, for our trainees who will be clinicians or are clinicians already, as residents are, right? And so I think that that's the challenge, is that we are not just academics. We're academics plus clinicians who are part of a profession.
Yeah.
And that changes the nature of that relationship.
Yeah, I think that you put that really well, that whatever you put out there should be something that doesn't drive a wedge between yourself and a patient or erode that sense of trust, right? Because all three of us in this room, we're on social media. We're all advocating in different ways. And I don't want people to view advocacy or being on social media as bad things. I think a lot of clinicians, because they don't really understand this, they tend to not do it at all, right? Because they're afraid of what might happen. But I think the world does need people like us that are advocating for what the right thing is and talking about these issues that aren't talked about enough. So in that sense, it is helpful to hear your perspective about how you can use social media and how you can advocate in a way that you are not putting yourself at risk.
Yeah, and I think advocacy and activism are actually different things as well. And I do believe I used to actually be someone who wasn't for free speech, which is maybe embarrassing for some folks. But as time has progressed, I've learned the importance of people being able to speak freely. And even if it might hurt, even if it might offend, even if it might be something that is horrible, I think I'd rather hear the person say it than not say it. And again, like you said, you deal with the consequences. It's kind of like that, the chart, the F around and find out, if it comes down that route, then it'll go down that route. But I also do believe that, we should have the right that if we see something that we don't agree with, or we see something that's harmful, that we should feel free and emboldened to have those types of conversations. And it should be a conversation. It shouldn't be a tweet. It should definitely be a conversation that's had amongst, many people in relation to whatever it is, the cause or activism that you might be pursuing. So again, at the end of the day, I think it's always about having powerful and important conversations. And sometimes those conversations can be not easy. Let's say that.
Yeah.
But important.
And I think the other thing that I'll add to what you just said, Amie, I think it was brilliant, is that it's also about knowing that I will defend your right to say it. I do not have to agree with the way you said it.
Right.
And I may still have an obligation as a dean of a medical school to provide you with feedback, to engage in disciplinary action if it continues, if you said it in a way that continues to harm and damage people, right? Because I think at the end of the day, that's the burden that I have as an educator, is that my job, and also as a fellow member of that profession, is that professions are self-governing. So it means that we actually have to do the work of governing each other.
Right. Yep.
And it means that we have to provide that mentorship. We have to have that crucial conversation, difficult conversation, whatever. Those are all trademarked. But the idea would be like, to actually pull someone aside and say, hey, what you said in that way was not cool. What you said was important, and I will defend your right to say it. But you need to know that by saying it in that way, in that medium, on that blog that has 10,000 hits a day, means that you have done this kind of harm to this group. And I'm not sure if you saw it that way. And if they're like, I saw it that way, I accepted that, and I'm okay if the college someone complains to me. So sorry, that someone complains to the college, and I'll go through that and I'll stand by it. Then I'm like, okay, great. You know that that's the case. You've accepted it. You've thought it all through. I am here to give you that insight and to provide you with the mentorship. However, I would say that 99% of the time with the learner, they didn't think about how someone could see that turn of phrase in a different way.
Right.
Or maybe they just didn't know that those 4 emojis in that sequence were also something else, right? And so there's so many layered meanings to the things that we do and the way that we convey things, that I think sometimes it's really more on the delivery that people are having the execution problem. I think that those kind of advocacy and communication skills, we spend a lot of time on interpersonal, one-on-one, patient, doctor, and I'm sure for you, nursing, and patient kind of like interactions or client interactions. But it's not the same as, like going to a school for PR and knowing how to craft a tweet the way that some politicians do, right? And so you sometimes don't know all of the ins and outs. And I think that that's where, as educators, our role is to make sure that a trainee who is going to like hold fast to something truly saw what everyone else was worried about. And I think only then can we say that we've done our job as educators. And if that means that sometimes there'll be a difference in opinion, again, that's not for us to decide right now in the moment, but look at the particulars. Right. And I think in an educational forum, we have to give people a chance to learn from those missteps in order to grow. And I think that that's where the nuance is. But again, it's so idiosyncratic. And sometimes a lot of that stuff has to be under the radar. You're not going to be live tweeting your remediation plan of a trainee either, right?
Right.
Because that's not cool. So from that point of view, sometimes to the public, it would look like, and to other members of the community, it might look like you're not doing anything.
Right.
And so that's where the challenge is that how do you keep something accountable? How do you report back to the community and yet also protect the trainee? And so again, I think these situations are very nuanced. And I think that there's a lot that we probably don't know about various scenarios in order to really draw judgment on how other people have handled other situations, because they're always fraught. And it could be that there's other things that, even though there's a public reason, there's also a lot of private reasons that during, let's say, a remediation plan, trainees may stray or it might unmask other things that lead to, consequences.
Yeah,
absolutely. Well,
I always believe there's got to be some form of a balance.
Yeah, I think so too. And Dr. Chen, you've touched on so many important things right now. I think I have so many takeaways, and I really appreciate everything you've talked about. I just wondered, is there anything else that you want to share, or maybe you could talk about if there are anybody out there that's interested in going to TMU medicine, any last things that you would like to share about the upcoming medical school?
Yeah, why choose TMU?
Yeah, so obviously pending our accreditation status in the fall, we're still waiting to hear at this point. We 100% need people who are interested in change, interested in advocating at the right tables in the right way, to learn those skills alongside our clinical faculty, alongside our administrative staff who are creating this medical school right now. I think what we're looking for is people who want to take their passion for equity in their hearts and their minds and actually parlay that into skills to be able to make change in these organizations. So we're looking for those people who want to be change makers, because guess what? When you're the first class of anything, you got a lot of change and you get to affect a lot of change.
Right,
so
right.
Not only are they going to actually be asked to do it someday, they're going to do it like on day 5, probably. Go like only aside in the hallway and be like, hey, so, like it would be really nice if, and, I'll text message someone immediately and say, hey, the students just gave me some feedback. Can we see what we can do about this, right? And so I think that's the really cool part, is that I look forward to thinking about how our students will learn those skills, micro skills at the beginning. But someday, I'm hoping, because we've built in things like health system science into our curriculum, that they're going to go to medical school. They're going to learn like, oh my gosh, this boring stuff about the health system. And then they're going to go to residency somewhere else. And everyone's going to be like, how do you know that? And like, what? You didn't learn that in first year? And then all the eyebrows will go up. Like, no, we learned about physiology.
Right.
And I want our students to have that gift of being able to say, oh, I learned about how the health system works, not just the way the body works.
Right.
I think that that's what we're heading into. Because the sickest patient right now in healthcare is the system, not necessarily individual patients, although there's complexity and all that other stuff.
Right.
But if we don't fix the system, everything else is just going to keep falling apart.
Yeah,
so
I wholeheartedly agree.
We want those people there. Now, if people want to find out more, they go to torontomu.ca/school-of-medicine. And we'll post when there's cool things and announcements right on that first page, but there's lots of places. And if you're a clinical faculty member who's interested in being a leader within our School of Medicine, just click on the careers button and you'll see some of our job postings. And I mean, worst comes to worst, there's lots of information on how to get in touch with me or others. So definitely check it out. And we look forward to hearing from you. And if not there, you'll probably see us at a conference or maybe at a barbecue, because we have barbecue, or other things like that. So because we're very engaged in the community, if you're in Brampton, there'll be that building. It's right by the mall. We're going to have our
by Bramalea City Center.
You got it.
Yeah, it's the old Brampton Library. So I'm kind of like, oh my gosh, it's like that. Like that's where I used to grow up to read books. So exactly. I know exactly where
we'll
you're going.
Still have a library in that same space. It'll just be a School of Medicine library now.
Amazing.
And the community library is like, it moved, I think, about 1.5 kilometers around the block, still near the mall. And it's in a beautiful new building that I'm super jealous of, because our building will be beautiful, but it won't be as nice as that. So it's really exciting to see, the engagement that we'll have, the opportunities that we'll have. And so stop by when we're open. And we look forward to welcoming you, Amie, as someone who used to grow up and be there, but also, Sarah, maybe you'd like to stop by and see what we're up to.
I love going to Bramalea City Center, so I'll definitely stop by. Sounds like a great place to be.
And then I think we'll be looking forward to the community engaging in our various formats that when we're having open events. If you're going to any event that's theater event in Brampton at the Lester B. Pearson Theater, you'll be coming through the atrium of the medical school. We're still going to have, city-based events. And so that's how we'll be
really nice.
Regularly into the space, right? So that's so exciting to me. And sometimes it'll be a lecture theater, and another times it'll be like someone will be singing like Annie, on the stage. So I'm just excited to see and have that community presence in those evenings and weekends when we can, right? So we're really excited to welcome the community into that space continually and for them to be a core part of what the school is about.
Yeah, you literally are in the heart and the hub of Brampton, right where you are. So you'll definitely get a lot of engagement. And I can tell you some of the best Caribbean food is in Brampton, or cultural food, Indian food. Oh my gosh, like top notch out there. So enjoy the space, enjoy the community and the people. They have my heart always. And thank you so much for coming on the Greeners podcast, Dr. Teresa Chan. It's always been a pleasure to have these conversations with you. And to eventually we'll be welcoming class 2025. Is that the year?
That's the year they start. When they graduate.
That's the year they start. Okay.
Yeah. So they'll be the class of 2029.
Wow, that's wild.
In 2025. And it'll be really exciting to watch them launch and for them to see them flourish. But before they show up, the residents start in July. So actually it's the residency classes that will start. And unlike the undergraduate, which it's still pending accreditation that I can announce anything, the residency programs are actually announced, and we've already put up some of our application information for many of our residencies that about half of them. The residency, kind of like senior residency spots that are open, such as the family medicine, emergency medicine program, or general internal medicine, or geriatrics, or care for the elderly, addictions medicine, sports medicine. So if you're a family medicine resident and you're like, where should I do a third year? Or if you're an internal medicine resident looking to do specialty in GIM or geriatrics, check it out because you might be interested. And if you're someone who's a doctor who's looking to teach and be a part of our mission, feel free to reach out because we're really excited to have people come on board.
Sure. And that's insider information. You heard it here first on the Gradient Nurse podcast.
Right.
So make sure you check that out. Dr. Teresa Chan, thank you again so much for coming on to our podcast. And we look forward to having you on again soon.